Sir, we are in live. Good to go.
Yeah. Hello.
Yes, sir. Please start.
So should we start?
Yes, yes, yes.
Uh, Good evening, everybody. I am Dr. Kushal Agarwal, a neurophysician working at Gondia at my own clinic, NeuroPlus Clinic. So we'll discuss about tremor and its management today, and we'll see a further differences between the essential tremors and Parkinsonian tremors and various other tremors and their management. So first we'll see start with the introduction. The tremor is usually defined as a rhythmic, involuntary, oscillatory movements of a body part that is brought about by alternating or synchronous contraction of reciprocally innervated. Hello, yeah, Praveen. Yeah, नहीं इधर तो चालू है. एक मिनट शो नहीं हो रहा है. बट मुझे तो अमित ने बोला कि स्टार्ट करना है. हाँ, एक बार अमित सर से बात करके पूछो ना क्या हो रहा है. अमित.
हाँ यस सर.
चालू करना है ना.
हाँ सर, चालू करना है. लाइव चालू हो गया है सर.
अच्छा. अरे Praveen has called me and he told me that nothing is visible on the screen.
Okay. No, Praveen might not be able to. He has to reload, sir. It's visible, sir. I have seen the viewer link. You continue, sir, please.
Continue.
Yes, sir. Please continue.
Yeah. Yeah. So first the introduction. The tremor is basically defined as a rhythmic, involuntary, oscillatory movements of a body part that is brought about by alternating or synchronous contraction of reciprocally innervated antagonist muscles. Tremor is basically classified under hyperkinetic movement disorder that are rhythmic and predictable. So, and it is one of the most common form of movement disorder. So basically, the classifications and characteristics. So tremor has been characterized on the basis of the frequency. Usually, the speed, what we call is the various known frequencies of the various tremors are being known. We'll discuss in detail later. The region of the body part affected, whether the tremors are there in arm or in voice, head, legs, that we'll discuss later. Activation state, whether the tremor is present at rest or whether it is present on action, on postures, that we'll discuss, and whether it has been associated with certain medical conditions like hypothyroidism, or whether it has been associated with certain drugs, that we will see, and various the tremor origin from various part of the brain like basal ganglia or cerebellum. So the latest proposed classification are basically the consensus guidelines recently divided the tremor into two main axes: the clinical feature, the axis 1, and the etiological feature, which is further divided into axis 2. So what all things were there in axis 1? The axis 1 is basically clinical features, which is further divided into historical features, tremor characteristics, associated sign, and additional laboratory tests. So the historical features like the age of onset, whether it is present in infancy or childhood, adulthood, or elderly. The temporal onset and evaluation, how the tremors has progressed, that also been very important in a clinical feature. The past medical history, any history of drugs or associated any underlying condition, as we have seen like hyperthyroidism, or whether any drug history, that is important. Family history, which is very important in essential tremors. The family history has been very prominently present in the essential tremors patients. Then alcohol and drug sensitivity, whether the alcohol by taking the alcohol, did the tremors reduces or remains the same, or any drug history. So we'll discuss in detail about the historical features. The second part is basically the tremor characteristics, the body distribution, in which part the tremor has been very significant, or which part of the body is involved, any activation condition, whether it is present in rare section, the tremor frequency, associated signs the signs of systemic illness along with tremors, any other movement disorder or any other neurological signs were present that we see, or any additional laboratory tests like EMG or any imaging characteristics. And accessory is basically the etiology, whether it is an acquired form of a tremor or genetically defined, or it is unknown, idiopathic, familial, or it can be sporadic. So, according to the age of onset, it can be characterized as infancy, whether birth to within a year to 2 year, or a childhood onset, adulthood onset, early adulthood, late adulthood, middle adulthood. That is also very significant to characterize particular tremor, to discuss and to see whether this tremor belong to that category. That is very important. Further, to delineate which kind of a tremor pathology is been there according to the age. So the age documentation is very important and should be very accurate in various cases. Anatomical distribution is basically the part of the body which has been affected. So it can be either focal, the tremor can just be in a voice, or it can be a jaw tremor or a head tremor, or segmental, either the two body part are affected, either the upper or the lower body part, like the hand and arm, the head and arm. When the tremor is bibrachial, involving both the hands or both the legs, whether it is a hemitremor involving one side of the body, whether it is a generalized form of a tremor present in the upper and the lower limb, and sometimes the tremor present in the lower limb or trunk during standing is usually called as orthostatic tremor. Yeah, Amit, it's going well.
Yes, sir.
Hello.
Yes, sir. Everything is going well, sir.
Okay, okay. I will continue.
Yeah, yeah. Please continue, sir.
So the identification of activation condition is also very important. The main two activation classifications are the rest tremors and the action tremors. So basically, we'll divide the tremors according to the activation, like the rest tremors, which are very common and prominent feature of Parkinsonian disease. So that is the one thing. Another thing is the action tremors. Now the action tremors can be further classified into the kinetic tremors, the postural tremors, and the isometric tremors. The kinetic tremors can be further classified as a simple kinetic, intentional tremor that we see more commonly in cerebellar disorders, or it is a task-specific kinetic tremor. Task-specific, like sometimes while writing, if the tremor comes, then it is called as a task-specific tremor. And the second classification is basically the postural. Postural can be a position dependent or position independent. It is called as a postural or isometric tremor. So because according to the position, it can be further classified. So for the clinical purpose, each patient usually will be classified in one of the syndromes listed here. So various tremor syndromes are action or rest, that is the ET or ET plus, or isolated rest tremors, or isolated segmental action tremors, or a physiological tremor. Then the focal tremors can be either present in voice, head, jaw, face, or a palatal tremor. Task-specific tremors can be a writing or sports or particular musician. Orthostatic, it can be either primary or it can be secondary. And tremor can be present with prominent additional signs like dystonic tremors, Parkinsonian associated tremor, then Holmes tremor, intention tremor, and other form of tremor like functional and intermediate tremor. So we'll go one by one. With first, we'll see a rest tremors. So basically, rest tremors are most common part of Parkinsonian disease. Uh, the rest tremor in the Parkinsonian disease usually starts in one side of a body, usually in one of the upper limb, and the tremors are specifically a pin rolling type. Why it is called, call it as a pin rolling? Because of the involvement of the thumb and forefinger. It appears as if the patient are rapidly rolling something back and forth between their thumb and forefingers. And this sometimes the tremor can be flexion extension, or it can be forearm pronation and supination movements along the wrist joint. So the most common one is the pin rolling. Then the other form of tremor like this wrist flexion extension, this kind of a movement, or either this kind of a movement. They are all common in PD type of tremors. And the tremor is more often prominent. See, this PD tremors are rest tremors which are typically more prominent when the patients are usually distracted or when they are walking, and the tremor frequency is usually 4 to 6 hours. So identifying a rest tremor in a PD patient is very very easy. You can easily make out, and by distracting a patient and by asking a patient to walk, you have to certainly see the tremor of a patient, whether it is increasing or decreasing, or what kind of a characteristic, whether it is a pill rolling type, flexion extension, or pronation supination. That you can easily see when you will allow a patient to walk. So we'll discuss certain cases. A 72-year-old male presented to neurology outpatient clinic for first time. He was previously in good health but noticed a tremor affecting the right hand and arm over the past 3 months. His wife, who attended him, she said the tremor is present in about 9 months ago. He generally noticed the tremor when his arms were relaxed, and it did not interfere with the use of the hand to eat or drink. That is the characteristic feature of a rest tremor. It usually goes away while doing certain activities. And he had noticed some difficulty with buttoning his clothes recently. So, on examination, the patient had a right-sided rest tremors with a pin rolling component. The tremors was absent on posture and doing action. He had a clear decrement in amplitude and progressive slowing of repetitive finger movement on the right and certainly on the left. So that this characteristic bradykinesia sequencing effect were present typically in right side, but it started in the left too, and rigidity was also evident on the right. He had a reduced arm swing on the right side, and the tremors were much more prominent when he was walking. So that is the very important thing to ask the patient to walk. So this is the classical history of a history and examination. It classically signifies that it is a PD patient. The key point is that while the tremor is typical for PD, it should not be relied on solely on. See, tremor presenting can be present. Sometimes it can be absent. So it is not like whether if the tremor is there, so it is a PD only. It can be something else. So apart from tremor, the PD patient should also have bradykinesia rigidity, which is the core clinical feature in a case of Parkinson patients. So Parkinson tremor, other facts we'll see. Some patients with a PD have a postural tremors as well, although this is only very rarely seen without. So the postural tremors are usually present along with the rest one, and the resting tremor is suppressed. Typically, the resting tremor is suppressed when the patient starts to move the trembling extremity. In some patients, a tremor on posture appears after they held their arm out in front of them for a few seconds. So it is called a re-emergent postural tremor. This re-emergent tremor are a kind of a postural tremor, but they usually appear after few seconds after the patient has kept his hand in a particular posture. Other patients have a high frequency postural tremor. Usually, some other kind of postural tremor which can be present in the ET patients usually appear without any time delay. As soon as the patient keeps the hand in a posture, the tremor starts. So this is not a re-imaging. This is a postural tremor in a essential tremor patients. And the patient with PD may also have tremor outside the arm, most oftenly seen in legs and jaw. So head tremors are not common in PD patients. That you should very well be taken care of, and while you are examining the patient. So head tremor is not a common feature. So certain pitfalls are the most common important pitfall is to assume that all patients with rest tremor have a PD, while other causes are much less common. It is important to keep in mind, especially if other feature in history, treatment, response, and the progression of symptoms over time do not fit in a PD. So everything should be kept in mind while assuming a patient with the rest tremor to have a PD. It is also important to note that tremor is not a cardinal feature of a PD, as is the rigidity and bradykinesia, because in 40% of the PT patients, sometimes the tremor may be absent. So the rigidity and bradykinesia is the most important thing to look into when you are discussing or when you are seeing the PD patients. So the other causes of rest tremors are, sometimes the rest tremors can be because of the drugs. So the most important drugs which our psychiatric colleagues are most commonly been using are the antipsychotic ones. Other are the antiemetic like metoclopramide and the anti-vertigo drug, which is being used left and right. That is the prochlorperazine. A careful review of medication is therefore a very important thing before assigning a patient to a particular syndrome. So the drug history is the most important thing. And sometimes the non-dopaminergic receptor blocking drugs like the calcium channel blocker, the lithium, the sodium valproate, which is very commonly being used in a seizure patients, the amiodarone, which is commonly used in a cardiac conditions, can also cause a asymmetric rest tremors, which can mimic a Parkinsonian tremors. So, and this rest tremor can also be seen in certain neurodegenerative disorders like multiple system atrophy and sometimes in vascular Parkinson. And other neurodegenerative causes of these rest tremors are basically the spinocerebellar ataxias can also produce these tremors. And rest tremors can sometimes be seen in patients of essential tremors and dystonic tremors. But the red flag is these tremors will be seen later in a state of a patient with the essential tremors, and that too they are not very significant. The most commonly will be the action tremors in an essential tremors patient. So we'll discuss a case two. Here, a 69-year-old woman described the gradual onset of tremor 7 years ago affecting her left hand. So the tremor here started in the left hand. She noticed the tremor when her hand was relaxed and also when she was holding and manipulating the object. So here, the tremor are not only been there at leg state, but also while manipulating and doing certain activities from the hand. So, and she was also aware of some very mild tremors of her right hand. So the left hand tremor very significant and right hand also the tremor were there. So other people had commented to her that she had a head tremor, but she was not aware of this. So this is also another red flag, the head tremors. And however, she was aware of some pain in neck and difficulty turning out to the right. So there is some neck pain, and also she had a difficulty of turning her neck to the right side. And she was diagnosed as a PD 5 years ago, and she was receiving levodopa for this. However, she did not notice any benefit to her tremor. So, on examination, she had an asymmetric tremors mainly of the right side, which is present at rest and more markedly on posture. She also had a slight head turn to left and no type of head tremors. On posture, her tremor on the right side worsened, particularly when she was in a this bat wing appearance posture. So bat wing appearance is this posture. When you ask the patient to keep the hand in this posture, it is called as bat wing position. So this is basically a postural component to elicit the tremors. She demonstrated some abnormal pushing of the finger and of the fingers and the wrist on left. There was no bradykinesia and rigidity. So that was the cardinal feature of a Parkinsonian patient. So here, this patient has a rest tremor, but main tremor is postural, and she had an additional hand tremor. So the main tremor on posture and head tremor are not commonly seen in a PD. That we have seen previously that the postural tremor and hand tremor will not be there. Postural tremor may be present, but it should be present in a patient who is having a rest tremor predominantly. In addition, she did not have a rigidity and bradykinesia, and which one would certainly expect. See, 7 years into the illness, rigidity and bradykinesia should have come if the patient had a PD. And as such, there was no response to a levodopa. That is also against the PD patients. So she also had subtle signs of dystonia. See, dystonia is basically abnormal movements and head posture, which is typically seen in this patient. So she did not have a PD, but instead she had an adult onset dystonic tremors. So the every point is very important. The every part of the examination which we are doing in a patient is very important. So everything should be taken care. Not only just the tremor, it is posture, the posture thing, the rigidity, the bradykinesia should also be seen in every patient of tremors to look into a particular specific clinical syndrome. So next we'll discuss essential tremors. Essential tremors is basically is one of the commonest form of a tremor typically seen in 60s and 70s. They're usually a bimodal peak one in usually in 20s and another in 60s, but 60s were typically more common. And ET tremors are usually bilateral, largely symmetrical, but can be asymmetric, largely symmetrical. Sometimes asymmetricity can be there, but it should be taken very carefully and seen very carefully. And certain more common tremors are postural and kinetic. So basically, ET tremors are the action tremors, and it is a kinetic and the postural component. Usually involves the hand and forearm. Because no diagnostic tests available for diagnosis of essential tremor, it is the symptoms are common to other disorder. It is important to be aware of the other cause. Patient with ET should not develop. See, if the patient is developing some other neurological signs like dystonia or imbalance or cognitive decline, then you should be very careful to investigate the patient carefully, not just labeling the patient as an essential tremor. Most patients with ET notice a very slow progression of symptoms over years, and some patients are severely affected. Hence, the change. Hence, initially it was termed as a benign essential tremor, but it has been uh, changed to essential because some patient can have a severe affection of the tremor, leading to a very difficulty disabilities in a patient. So we'll see a case 3. A 70-year-old man reported a tremor present in both arms, which he noticed mainly while holding the objects or moving his hand towards objects. He had been aware of tremor since the age of 50, and very gradually it had worsened. He described no other symptoms. He had a family history of a similar tremors in father and brother. On examination, he had this bilateral, largely symmetrical postural and action tremor. No other clinical signs were present. So this is a typical case of essential tremor. The history and the examination is uh, typical of the essential tremor. So long duration of tremor without any other symptoms developing over time is typical, and relatively mild to moderate severity of a tremor itself. The family history also important. In this case, the brother and the father had the history of the tremor, so that is also a significant point to consider essential tremor. So certain essential tremors patients had some soft signs, which are neurological signs that are not very typical to assign the patient into particular diagnosis, but these features are there. So if the essential tremor patient has this particular syndrome symptoms, then it is called as an essential tremor plus, and can convert into some other syndrome. Like sometimes the patient may land up in some other diagnosis or degenerative disorders. Like sometimes the soft signs may be a rest tremor that can be present in a later stage of an essential tremor patient, or can be present initially. That is the red flag if it is present initially. Sometimes tandem walking gait is impaired. There is a dystonic posturing of hand and head. Memory impairment or cognitive involvement can be there. Sometimes mild sensory neuronopathy, or jerky tremor, myoclonic component can be there, or markedly asymmetric upper limb tremor. So these are the certain soft signs which you should always look in a ET patients, and always keep some other DDs or the differentials in mind while assigning this patient as a ET. In now the third form of tremor and the dystonic one. Usually, these are present in a patient who had been diagnosed as having a dystonia, which is one of a kind of a hyperkinetic form of a movement disorder. Usually, it affects the uh, limbs that exhibit the dystonic posturing of a movement, and in limbs that do not exhibit this. See, the dystonic tremors can be present in a limbs which had a dystonic posture, and sometimes also in a limb which do not have a dystonic posture. So you have to look everywhere. Furthermore, the tremor may occur in limb at rest. This tremor can be present even at rest and can be present even while the limbs are in active state during a sustained posture or during voluntary movements. Tremor in a patients of dystonia are not very regular. This is the one of the most important point in a dystonic tremor, that how to differentiate from the essential one. Dystonic tremors are usually present in particular posture, and they are not regular as the essential tremors are. Patient with dystonia may exhibit a variety of sustained posture or twisting movements involving, it can involve the neck, it can involve the hand, it can involve the limbs, or it can even involve the abdominal muscles also. Patient may also exhibit one or more of variety of dystonic posture during the arm extension, difficulty in maintaining both hands strictly parallel with outstretched hand in a karate chop position, thumb flexion during arm extension. This should not occur. Usually, these features are not present in essential tremors patient. So it should be very carefully taken care of by you are seeing the patient that whether some dystonia is present or whether the tremors are regular, other which part of the body has been affected, whether the tremor are present in only a dystonic posture or it is present in some other posture also. So it is important to differentiate the dystonic tremors from the essential tremors. Sometimes it can be very tricky, but certain important points should be taken care of and patient should be examined very carefully to look into this certain clinical features. Patients with neck dystonia are usually called as a torticollis, can have a tremors. Tremor is generally neither. See, this tremor in dystonic patient are not rhythmic, they are not even oscillatory, and this are usually accompanied by certain dystonic posturing. Sometimes even in neck, if the patient had a sustained neck deviation, there can be there the tremor can be there. There can be a hypertrophy of the neck muscles. Sometimes the tremor are only present in boys, so they are called as boys vocal cord dystonia. That is a spasmodic dysphonia. This boys dysphonia are different from the boys tremor of essential tremor patient is often seen. Voice tremor in a dystonic patient usually have a voice break or strangulated speech, which is not commonly seen in an essential tremor patient. And usually, the essential tremor patient will have some form of tremors involving the head or the hand that you have to carefully see into. So, case 4, a 56-year-old woman presented with a chief complaint of head tremors with some mild associated right hand neck pain. The pain had begun 10 years previously. For 4 years, she had also felt an intermittent pulling sensations in her neck. She further noted that her head had been turning to one side and sometimes it is even felt a little shaky. She did not report any tremor in her hand. So on examination, she had a mild to moderate postural tremor of the right arm with little bit of flex posturing of her index and middle finger. On finger nose finger maneuver, no tremor was observable, so intentional component was not there. On examination, the sternocleidomastoid muscles was hypertrophied, and the head tremors persisted even when she lie down on her back on examining, which is the typical feature seen in dystonic patient. Usually, the essential tremor patient's head tremor usually will not persist while the patient lie on a back with head been laid down on an examining table. She was treated with botulinum toxin, which helped her symptoms got relief. So this illustrates very important feature of dystonic head tremor. The tremor is often non-rhythmic and is often persistent in recumbent position. So furthermore, it may be accompanied by pain, pulling sensations of a neck. So the tremor in a dystonic tremor are usually the triaxphenidale or either baclofen or beta blocker. For dystonic neck tremor, the botulinum toxins are very useful, and sometimes the surgeries like the deep brain stimulation surgeries are also very helpful. Now we'll look into a primary writing tremors. So primary writing tremors are classified under a task specific tremors. This tremor usually comes while the patient is writing. So the current definition of primary writing tremor usually exclude the dystonic posturing. So the writer cramps is different from the primary writing tremors. Sorry, the primary writing tremors will not have the dystonic posturing. If the dystonic posturing is present, it is called as a writer's cramp or a dystonic tremor. But in primary writing tremor, it will be a tremor without dystonia. And this tremor are usually sporadic or can be inherited. The frequency is about 4 to 8 hertz, and the tremors are usually relieved with ethanol consumption. The mechanism is not very well known, but it has been said that it can have some hereditary factors also. So the treatment here is the primidone, which is very commonly used. Then your propranolol can also be used in this form of tremor. Anticholinergics like triaxpenidil and the IM injections, botulism can be used in this patients. Finally, some patients will switch to, sometimes even some patients switch the writing hand to basically a other hand. So see, the knowing about this tremor is also important. Though they are not very common in day-to-day practice, but you should able to differentiate it from a dystonic one and be able to differentiate and treat it well with proper drugs which has been assigned for this syndrome. So one of the common form of tremor, though not very common, but they are very specific. The orthostatic tremor, though they are very rare and they usually are characterized by unsteadiness on standing and high frequency tremors in leg. This tremor only come when the patient is standing. As soon as the patient start walking, the tremor go away. Or while patient is sitting, the tremor is not present. They usually comes in 6 decades, and most of the cases are sporadic. Sometimes family association are also be known. Patient more often note unsteadiness while standing rather than the tremor person. So they will not call it as a tremor. They will say unsteadiness while standing. Because of the symptoms, patient typically avoid the situation in which they have to stand. So they prefer sitting or being lying down rather than standing because they typically feel unsteadiness, which they feel very bad even in the places, in the situations they not prefer to. On examination, the tremors are usually very rapid, 14 to 16 hertz. They are the fastest tremor been known till now, and fine one. Due to high frequency and low amplitude, orthostatic tremor may be difficult to appreciate on visual inspection. So sometimes even the surface EMG can be done to see the tremor frequency and to know. So the cerebellar tremor. This tremor are basically a cerebellar, classically used to describe tremor that occur in patient with this tremor usually comes in a patient who had a spinocerebellar ataxia or some form of cerebellar cerebellar involvement in form of any structural involvement, like patient is having a stroke or some structural involvement in form of tumors or any infection or degenerative disorder. The tremor typically comes in a picture. So they are basically a intentional tremor. Intentional tremors are tremors, these are basically a goal directed tremors, while finger to nose maneuver and worsens while approaching. See, while approaching an object, this hand tremors usually worsens. However, cerebral tremors are tremors cerebral origin do not always present exclusively as intention. Some form of action component is usually there in cerebral tremor. So cerebral tremor include kinetic tremors, the postural one, the resting, the orthostic tremor, but intentional component is most common one. So always look the intentional part of a tremor while performing the finger nose test. On examination, patient with classically defined cerebral tremor often have other cerebellar signs that you have to see gait ataxia, abnormal eye movements. A number of medication have been used to treat, but they are not very efficacious. And sometimes the surgeries can be very useful in tremors like DBS surgery. Can sometimes use. The home tremor are basically a tremor which originates from the midbrain. So the home tremors are usually a unilateral, either involving a single limb with a frequency of 4 to 4.5 hertz. In this, basically, it is a combination of intentional tremor and rest tremor. The rest tremor worsens with posture, while with still more worsening on action. So the rest component, the postural component, the action component are typically all there in a home tremors, and they are usually unilateral as I have spoken, and they usually arises from a midbrain lesions about 4 to 4 weeks to 2 years after the onset of the uh, this problem. It is postulated to occur during involvement of due to involvement substantia nigra or sometimes cerebellar outflow tract involvement which passes through the midbrain can cause this form of tremor, most commonly seen in strokes and tumor involving the midbrain. And psychogenic tremor. These are this by history the tremor is basically in a patient who are psychogenic or functional tremor often has an abrupt beginning. Say this tremors have abrupt beginning and their maximal tremor at onset rather than an insidious onset followed by slowly. So they are not basically a slow onset and progressive kind of tremor. They are abrupt beginning at the onset only, as it typically see the typicality of the organic tremors are the onset is very slow and the progression is comparatively progressive in nature. Though this functional tremor are not progressive, they are usually abrupt beginning. Also, the tremor may fluctuate and have a period of remission. And this tremor, this on examination, the tremors has non-physiological or unusual features. See, this tremor may exhibit variable frequency. The frequency will not be very common like the variable. It will be very variable. The tremor may changes in direction, and there is a combination of tremors. Like sometimes same patient may have a resting, same patient may have a postural or kinetic tremors. Positive signs. So these positive signs may have to be elicited in psychogenic tremor, like while entertainment, distractibility, or suggestibility can bring about this tremor. Furthermore, many patients have some excessive exhaustion during examination. Of note, during quantitative, sometimes a quantitative loading may bring about the increase in a tremor, which should usually be decreased, while if the tremor are organic one. The treatment is basically you have to counsel the patient, and you can even refer the patient to a psychiatrist to evaluate underlying psychiatric issues. In cognitive behavioral therapy is also very important. So the Wilson tremor. So Wilson tremor are basically a postural and kinetic. The wing beating tremors is a very important tremor in a Wilson patient. This wing beating posture is this when the patient shoulder is abducted to 90-degree and elbow splits. So this is a wing beating position where you have to look for the Wilsonian tremors. So this is one of the example of proximal postural tremor. And in Wilson patient, you have to look into the other neurological deficit as dystonia, rigidity, coriform movements, which are typically more common in Wilson patient. And tremor in peripheral neuropathy patient, sometimes the neuropathy because of the demyelination or your connectivity disorder can be associated with this peripheral neuropathy. So now into the conclusion part of a tremor discussion. So the most important thing in history is the age of onset. So age of onset is one of the most common thing you have to look into. Body part, what body part is being affected. Accordingly, you can classify the tremors. The nature, whether it is an onset, whether it is a sudden onset, whether it is an insidious onset, the course of tremor, whether it is a static or progressive, exacerbating and relieving factors, whether some kind of a drugs, or whether alcohol, or whether resting position, or whether doing some activity, whether this tremor worsens or get corrected, associated neurological symptoms, any systemic symptom diseases like whether patient had thyroid or diabetes, drug history is very important, family history is also very important, typically in essential tremors. And the examination part, you have to examine the patient very thoroughly. You have to examine the patient with arm at rest, with arm outstretched, with arms outstretched in front, with the arm abducted, as I've shown you in this wing beating position. You have to see the pronation, supination of an arm, forearm. The examination during movement like finger nose test, that is very important to elicit the intentional tremor, action tremor in a patient. In certain patients, you can ask the patient to write and draw a Archimedes spiral to bring about task specific tremor, like a task specific like writing tremors or essential tremor. You can ask the patient to draw Archimedes spiral to elicit certain tremor. And you have to examine the patient thoroughly to look into the certain neurological signs and symptoms, like some patient can have a pyramidal signs, some patient can have a dystonia, other form of movement disorder like myoclonus or chorea can be present. You have to consider certain systemic features like in a patient of hyperthyroidism, whether the thyroid swelling is there, eye signs are present, that you have to see. You have to look into the cushingoid faces. You have to ask the patient for a drug history. You have to see certain toxin exposure. Because of the toxin exposure, there are certain changes in the nails, hairs, and in the skins that you have to take care while examining the tremor patients. So certain investigation in the tremor cases are basically in enhanced physiological tremor. You have to look into what is the pathology behind the physiological tremor enhancement. Whether because of the diabetes, because of the hyperthyroidism, you have to look into the TSH, liver pathology. You have to evaluate whether patient is having some kind of anxiety or whether patient is taking drugs or caffeine use. Essential tremor, usually there is no specific test, but you have to rule out whether it has been associated because of the thyroid thing, or you have to rule out other physiological tremors, basically you have to see for the drug issue also. Parkinsonian patients, basically no specific test, but you can do a PET scan or specs to see the you can see the uptake in the substantia nigra, whether it is poor or good. Accordingly, you can diagnose the patient apart from the clinical feature. Then your cerebellar tremors, you have to look into the structural pathology by doing imaging like CT, MRI. Or young patient less than 40, then you have to strongly think of Wilson's disease. In that case, KF ring, you have to see ceruloplasmin level, urinary copper level, or screening of the heavy metals. Orthostatic tremors, you have to see the EMG to look into the tremors. Then medications, medications for the tremor treatment, usually in essential tremor, the most commonly used drug is primidone and propranolol, which should be used very carefully and very properly. With these medications, the tremor can be subsided by usually taking the drugs in a proper dosages according to the physician who is prescribing this drug. So, apart from primolidine and propranolol, clonazepam can be used. Botox injections are basically being used in a refractory cases, not responding to medications. Then your dystonic tremors, a response usually to the clonazepam or your trifexpenidale Botox injections can be given. Then Parkinsonian tremor, levodopa is the drug of choice. Then dopamine agonist, antagonistic drugs. Cerebellar tremor, usually the drugs are not very useful, but you can try the carbamazepine, topiramate. So, interventional intervention in essential tremor. Sometimes DBS can be done. Dystonic tremor also, DBS is the useful thing which can be used in certain patients which are not been responding to drugs. Parkinsonian patient also DBS and GABA-NEC, thalamectomy. Cerebellar patients also thalamic DBS has been shown to have various good effects. So, what is the basic difference between the Parkinson and essential tremor? The essential tremor are basically action tremor, predominantly action tremor, and essential tremor. And the Parkinsonian tremors are predominantly resting. Essential tremor can be present in all age groups, and Parkinsonian is usually in more than 60s. Family history is typically present in essential tremor, which is usually negative in Parkinson's. Alcohol response is beneficial in essential, no response in Parkinsonian. Tremor onset is usually bilateral and unilateral in Parkinson. Muscle tone, usually the rigidity is typically seen in Parkinsonian patient. Facial expression are decreased in Parkinson patient. Gait are normal usually in essential patients, essential tremor cases, and in Parkinsonian decrease in the arm swing. Tremor latency during hand suspension is the re-emergent quality, which is typically in Parkinsonian, not in essential. So you can see the writing in patients of the micro PD, in which the writing has been very small. So it is called as a micrographia. And here the handwriting of a ET patients, which has been very, it has been very easy. It is going haywire here and there because of the tremor component. So in conclusion, tremor is a frequent neurological entity faced by physician in day-to-day practice. So proper evaluation, examination, history is very important in tremor patient. A comprehensive knowledge into the tremor characteristic, etiology, and the algorithm approach will help the physician from ordering unwanted investigation and guide into a quality management of a patient. So it is very important to properly first examine, take history properly, and then properly then investigate accordingly. Not every patient here in a tremor needs the MRI or CT scan. It is always the clinical features and your history that is the most important thing to decide for the treatment as well as for the your investigation part. Thank you. Hello.
Yes,
Hello.
sir. Yes, sir.
Yeah, Amit.
Yeah, sir. It went very seamless. I mean, all audio visuals were perfect throughout the session.
Yeah.
Yes, sir. So
So should we leave now?
we can leave. As I can see in the audience section, we have not received any question. So if anybody of the audience have any question, please put in the chat box if you have to take that questions. Otherwise, we can close, sir.
Okay.
We'll just wait for 2 minutes. If some questions come, else we can close, sir. Thank you, sir. Thank you so much.
So I will leave now.
Yes, sir. Thank you, sir. Thank you. Good night.